Good morning, everyone. You are very welcome to the Why Chronic Disease Prevention Works, Making Every Contact Count webinar. The panel will be delighted to receive any questions you may have. Please use the Q&A feature located at the bottom of your PC or laptop screen. If you are using an iPad, you will find this feature located at the top of your screen. Without further ado, I will now hand you over to your host, Sandra Coughlin, Training and Programme Design, HSE Health and Wellbeing.
Good morning, everybody, and my name is Sandra Collin. I'm the National Lead for Making Every Contact Count programme, and I work within HSE Health and Wellbeing, and delighted to welcome you all today to our webinar on Making Every Contact Count, or MECC, and why chronic disease prevention works. So over the next hour or so, we're going to talk a little bit about how we got to this event today, the context and backdrop to a lot of work that has happened over the last number of years, and also to talk a little bit about the positive impact that Making Every Count is really having in a range of healthcare settings, and we have hopefully the opportunity to showcase really excellent examples of that over the course of the next hour or so. And then we really want to look at next steps and where to from here. So that will be part of our panel discussion as we go through. So we have a number of different speakers, and delighted to have a range of speakers this morning. And we also have a number of video collages to outline, again, further examples. And then we want to also then have a really good panel discussion at the end, where we really appreciate and welcoming your questions into our chat box, like Jean said at the outset. So looking forward to the hour or so ahead, and hoping that you really enjoy the program that we've got lined up. So just before we move on, just to say why we're here, or the kind of the core rationale for why we're here this morning. We know that chronic disease is a huge burden for our service users and our patients, our communities, and the health service that we all work within. And we know the risk factors that contribute to chronic disease, and we know that chronic disease is largely preventable. So there's a huge amount that we can do to support our patients, our own families and communities, and the health service that we work within. So we know that brief interventions are effective, and we know that we have lots of opportunities in our routine day-to-day work with our patients, clients and service users. So today is about looking at how we can make the most of those opportunities and make every contact count. So without further ado, our National Director, Dr. Philip Crowley, is unavailable to join us in person this morning, but has sent a recording welcome to open the webinar today. So without further ado, I'll hand over to Dr. Philip Crowley, our National Director. Thank you.
Hello, everybody. Philip Crowley is my name. I'm the National Director for Strategy and Research in the HSE, and thank you to Sandra for both organising this really important webinar and for asking me to say a few words at the start. I'm sorry it's recorded. I was unable to come on the specific day, but I can see from the webinar outline it's going to be really, really important webinar. Great to have so many examples from community services and acutes being presented today of where we are making every contact count. Great to be in partnership with the Irish College of General Practitioners and Dr. David McConaghy, because the college have been really to the forefront of work on prevention through David's work. And we all know why prevention is so important, because let's face it, the cost of delivering healthcare is unaffordable. It's not only unaffordable in Ireland, it's unaffordable everywhere. The costs of medications keep going up, the burden of chronic disease keeps mounting, and it's largely preventable. So it's simply not an option to not commit to prevention, I think, as a healthcare service, and as individuals, I think, who care about healthcare. The impact of healthcare on the environment is also unsustainable, and obviously I lead on climate change as well. And I think the links between this work on making every contact count and climate change are very direct. So we can prevent illnesses, then there'll be less impact on the climate through people making unnecessary trips to hospitals and community centres. Behaviour change is difficult, though, and people's circumstances for changing the behaviour are unequal. Some people have a lot more resources around them to help them make the changes they need to their behaviours so as they can become more healthy. Others do not. So I think in healthcare, The thing about, I feel anyway, about people who come in to see me as a GP, they're thinking about their health when they come in to see me, and it's a teachable moment. So I think we need to use that moment to use the brief interventions that we learn through the Making Every Contact Count program to actually make an intervention on somebody's obesity or smoking or whatever other behavior change we feel it will help them become healthier and live a better lifestyle. So we need to make every contact count, and we know that this works. It's been proven to work, and it's working in general practice in Ireland now in the chronic disease program. It's working across community services, as we'll see later on, and in some acute services. And training numbers are increasing, so that's excellent. But prevention is critical, and it's going to be critical in the regions as well. As the regions evolve, we'll be working with the regions to make sure that the Healthy Ireland programme is central to their work. And I think that it's really important to remember how many of you are already championing this, and that you're using the fact that your role is respected to play this additional role in trying to help people go down a healthier behavioural route that will lead to a healthier life in the end of the day. So I think we must scale up MECC. It's Making Every Contact Count is well embedded, but we need to spread it out. I really thank you all for your support, and many of you are champions of this, and many more of you could be. So I think we'd be making a great contribution to the future of healthcare in Ireland. And just to say, really, I think we all know we need to get serious about prevention. And we need to make our clinical interventions as effective as we can do. And part of that is definitely making every contact count and really focusing on prevention. So thank you all very much for today. And I really hope you have a really good webinar. It looks like it's an excellent program. Thank you very much.
Okay, thank you very much to Dr. Philip Crowley for that great welcome opening for our webinar this morning. And Philip is a really great ally for the work that we're doing in health and wellbeing, and specifically in our Making Every Contact Count program. So thanks very much to Philip for doing that. And now I'm moving on to welcome our keynote speaker, Dr. David McConaghy, who is the lead for prevention in the Irish College of General Practitioners. Delighted to have David joining us this morning to give us the GP perspective in terms of making every contact count, where there has been great strides in terms of really putting this approach into action in a systematic way, and some great results to share with us in terms of that as well. So welcome, David, and thank you. And I'll hand over to you there now. Thank you.
Thank you very much, Sandra, and a very big welcome to everyone who's joined us today on the webinar. Thank you very much for the opportunity to talk today about MECC. It's a very important concept, as Philip has mentioned, for our patients, our individual teams, for society, and the sustainability of our health service. In the last 20 years, we've seen the Irish population grow by 1 million people. People are living longer, but they often do so with disease. And our health service must move to prevention focus rather than a focus on illness if we're going to make our health service sustainable into the future. Very good. So hopefully you can all see my screen. So just a little background about me. My main job is I'm a GP. I work in Sallins in County Kildare. I work for the Irish College of GPs as a prevention lead with an emphasis on cardiovascular disease. I'm also proud to work for the HSE as part of the integrated care program in chronic disease. I'm one of the leads there. And I'm passionate about preventing illness and managing chronic disease. These are my conflicts. So today, if you allow me, I'm going to try and outline the GP chronic disease program, look at how it's structured and its successes. It's been around for a while, but not everyone is familiar with it. And then I'm going to look specifically at how GPs and our GP nurses make every contact count. And hopefully by the end of this, we'll encourage and inspire you to make it part of your daily practice. Looking at some numbers nationally. So every day in Ireland, 3,300 people will attend A&E. 13,000 people will attend an outpatient's appointment. 77,000 people will attend a GP practice or a GP out of hours each day. So 90% plus of all sick people actually are outside the acute hospital setting. General practice teams, which I'm part of, we generate 350,000 prescriptions every day, vaccinate 1,000 children, do 1,300 ECGs, and 1,700 chronic disease checks every day. So across both primary and secondary care, we have lots of opportunity to make contacts count. So when it comes to making interventions and counselling patients, often what I hear from everyone I encounter is that we're just too busy to counsel patients. So Muhammad Ali had a famous quotation, "Don't count the days, make the days count." So my take on this is, don't count the consultations, make the consultations count. So we have numerous opportunities to encourage our patients to improve their health and live their healthiest lives. And by doing this, we can prevent misery and reduce healthcare costs. Chronic disease, is it important? Well, yes. If you're aged over 50, half of the population have one chronic disease. Almost 1 in 5 have 2. So there's a lot of, to summarize this slide, there's a lot of chronic disease around, and it's on the increase, and it takes up a lot of hospital bed days, visits to GPs, hospital admissions, and 3/4 of all deaths. Next slide, please. So as Philip alluded to, if we don't get prevention right, our health service may not cope in the future. So the mantra should be prevent more and treat less. Next slide, please. So why should we get involved in behavior changing with our patients and the population? Well, a lot of the conditions and risk factors that lead to chronic disease are modifiable, and we could prevent 90% of a disease if is preventable. Disadvantaged individuals are affected disproportionately, and certainly there's no doubt that poorer neighborhoods people who live in poorer neighborhoods do not enjoy as good a health or live as long as those in wealthier neighborhoods. And prevention works. There's an evidence base for it. So 41% of heart disease can be prevented due to primary prevention, 30% due to secondary prevention. Next slide, please. So the chronic disease program, how did it start? So this is a contract was agreed in 2019 between the HSE and GPs throughout Ireland. The program commenced during the pandemic in 2020, and we started looking at chronic disease in older patients, and now we progressed down to younger cohorts, so everybody from 18 up. Uptake has been very good. Over 90% of GPs in Ireland participate in this program. And recently we recorded our 1 millionth checkup. Next slide, please. Before the chronic disease program, what happened to people living with chronic disease? Well, general practice teams would deliver a lot of this care, but it wasn't structured or funded. Some patients went to an outpatient hospital to see a specialist team. Now it's more structured. And whilst we're somewhat late in Ireland to the party, I'm still glad we're at the party. But similar projects have been running for 20 years in the UK, and even since the 1980s in the United States. And Kaiser are a health organization in California, and they've been doing this for many decades. Next slide, please. So who can participate in the chronic disease program? You have to have a chronic disease, and I'll talk more about that later. You have to have a medical card or a doctor visit card and be aged over 18. The only exception to this is women who have had a history of gestational diabetes or pregnancy-induced high blood pressure. They can join the program as long as this happened. Their diagnosis has been made since 2023. Next slide, please. The conditions, so what chronic diseases are covered at the moment? Well, heart disease, type 2 diabetes, asthma and COPD, heart failure, atrial fibrillation, and stroke disease. High blood pressure is also covered, which is a very positive. Pre-diabetes, and people whom we see that are at higher risk of heart disease down the line. And then, as I mentioned before, women diagnosed from 2023 on with high blood pressure in pregnancy and diabetes in pregnancy. And then every 45-year-old, if their GP feels that they're at high risk of cardiovascular disease, they get a free screening every 5 years. Next slide, please. So the process, so what does a chronic disease check involve? Well, it's an entire team approach. The general practice team are going to identify the patients. Our administrators call them in 2 times a year. Then they see the nurse first, and nurse examines them, does bloods, ECG, it depends on the condition, and then they're reviewed by the GP. And then if changes are necessary to their treatment, GP organises that. But the good news is that 90% of these patients don't need to be referred on to a specialist clinic or to a hospital. Their care is delivered by their practice nurse and their GP. Next slide, please. Things that we check: blood pressure, body mass index, their heart rate and rhythm. We ask specifically now, and this is relevant to MECC, about smoking, vaping, exercise, alcohol, and then we do various tests depending on the condition under care. Next slide, please. Has it been a success? Yes, is the answer, I'm glad to say. We've noticed that even at this stage in the first 4 years, cholesterols are falling, and this prevents heart disease in the future. Blood pressure is falling, and this prevents complications in the future. And diabetes control has improved. Next slide, please. Quite positively, smoking rates are falling in the groups that come for chronic disease checks, as is weight. And the good news, our latest stats were that if in 2023, if a patient was participating in the chronic disease program, there was a 16% reduction in admissions to hospital. And if they were admitted to hospital, there was a 30% reduction in being readmitted in the month after. So this is very positive. Imagine we had a medicine that could reduce admissions by 16%. Well, actually we do, and it's the GP chronic disease program. And again, the good news for the health service and sustainability is that 90% of these patients are able to be looked after away from a hospital setting. These slides briefly show on the left, you see that over 3 visits, blood pressure, people diagnosed with abnormally high blood pressure has fallen. And on the right-hand side, you see that diabetes control has improved as well. And the diabetes control on the right, that's important because if you can get blood sugar under control, you can prevent blindness, you can prevent limb amputation, which is very positive. Next slide, please. In this slide, this just shows 3 groups and how their cholesterol has fallen as well. And again, down the line, this will prevent heart attack, strokes. And the next slide, please. And then lifestyle changes. On the left, you see that 14% drop in smoking. The middle column showed that obesity levels were dropping as well. And on the right, that more people are taking up the physical activity. Again, very positive. Next slide, please. So sort of interim summary at this stage in the presentation. I've sort of shown how the CDM program came about and its successes. And now I'm going to look, if you'll allow me to talk about how GP teams make every contact count. Next slide, please. So the power of MECC. MECC makes prevention everybody's business and part of clinical consultations. As Philip was saying, it's for all healthcare staff across the HSE. It's a recognized brand. Most people who meet know what MECC is. It's got an evidence base, and it's a fundamental plank in health improvement and behavioral change. Next slide, please. So partnerships, none of us can work in isolation, and obviously the MECC team have linked in with third-level institutions, professional bodies, training commissioners, HSE partners, and my college as well. Next slide, please. So, as I've shown before, GP teams have embraced the program, and everyone who attends for a chronic disease review gets asked about exercise, smoking, alcohol, and have their body mass index checked. It's very quick. It takes 3 minutes, probably less. And as I've shown earlier, modifiable risk factors have improved. The mental health service are also quite passionate about MECC, and this is really important. People with major mental illness don't enjoy good physical health, and this is something that we need to be cognizant of and address. Next slide, please. So the progress to date. So the framework for MECC was developed in 2017 by Public Health. It's been on HSE land since 2018. It's part of the undergraduate curriculum. Various professional colleges, the College of Physicians and our own college, the College GPs have embraced it. And as I said before, it's in the chronic disease contract. Next slide, please. So the important thing here on this slide is the pyramid. So at the bottom, brief advice, which we can all do. Brief intervention, which takes a little bit more time, but we can all do. Extended brief intervention, which many of us are capable of, and then specialist services. So if we can get them up the three purple parts on the pyramid and then nudge them towards specialist services, this can only do good. Next slide, please. So a brief intervention, it's the 5 A's, which many of you are familiar with. Ask them about the behavior. Tell them they need to change. Work out or assess, are they ready to change? Assist them with exploring the barriers to that change. And then if they need support, arrange that. So 5 A's, very important. Next slide, please. So I'm going to give you 2 case examples of what goes on in the average general practice. And these are real patients, but their names obviously have been changed. So Jenny smokes 20 cigarettes a day, and she comes along to her GP practice nurse for her chronic disease review of her COPD. So the nurse asks her, are you still smoking? Yes, I am. And nurse will say, you need to give them up. It's not good for your COPD and your health. So Jenny says she's willing to try again to stop. And many smokers who have stopped, ex-smokers have had a few attempts to stop. Nurse then explores with her the challenges to smoking and assists her with a referral to HSE Quit, which thankfully GP practice can do electronically. There's no paper involved. The nurse also then discusses with the GP about Jenny's willingness to change, and GP prescribes dual nicotine therapy, in this case, patches and nicotine spray. And then 6 months later, when Jenny's back for her next checkup, she's not smoking. And this is really positive because by not smoking, Jenny is likely to live longer, live healthier, and not be utilizing the health service. Next slide, please. The next example is a patient of mine who had a myocardial infarction or a heart attack last year. He comes to me for as part of his chronic disease review, and we note that he's completed cardiac rehab, which is worm. So we ask him about his exercise, and it turns out that he's not taking any exercise at all. I explore with him the issues, and it transpires that Nat's worried that if he goes exercising, he'll give himself another heart attack. So he and I tease it out together, and he feels reassured and he's willing to try. And so I encouraged him to go off and start with 2 20-minute walks a day. What I told him was that to put on his most comfortable shoes, go to the front gate of the house, and set the timer on his mobile phone for 10 minutes. I then encouraged him to walk gently for 10 minutes. And when the alarm went off, turn around and walk home again. And in that way, he'll have covered 20 minutes. At a 6-month review, then 6 months later, I discovered that Nat's now walking 60 minutes 5 times a week, which is, again, was brilliant. It reduces his chances of cardiac complications and will keep him healthier for longer. Next slide, please. Thank you. So patients and MECC, there's an awareness now amongst patients that their nurse, their doctor, their healthcare professional is going to ask them about behaviors. And so people now expect to be asked. There's also in many areas, we have better access to supports. As we go towards the top of that pyramid, there are more supports to help us. And I know in examples in a general practice setting, I now have in my locality, I have access to exercise through a program called Xwell. I have access to smoking cessation counsellors, pulmonary rehab, all these things as well to encourage people along. I think as health professionals, and I keep telling myself this as well, I have to be mindful of health literacy and the people that I'm advising and to keep it simple. And for example, my patient Nat would never be the type of gentleman that would go to a gym, but he would go walking with one of his friends. And certainly patients in Mairead, we encourage them to pair up with a friend to go walking, or sometimes through men's sheds, women's sheds as well. There are groups where they go walking, a couch to 5K. group might be in your area, and also Park Run on Sunday mornings, which are all over the country, are all places that I encourage people along for exercise. Next slide, please, Jean. So MECC works. The international evidence said that after an intervention by a doctor, that 1 in 8 will lower their alcohol consumption, 1 in 12 will increase their physical activity, 1 in 32 will stop smoking just by someone telling them you should stop smoking. And if you can add in anti-smoking medication, you can double that number. But in my opinion, it works if it's delivered by any healthcare professional. Next slide, please. So my final summary, I'm glad to say I'm coming near the end of this. The General Practice Chronic Disease Programme has been an overwhelming success. For all of us in the health service, brief interventions work. It doesn't take up as much time as we think. I think a big worry, I often talk to doctors in training, and they worry if they open up a conversation about a lifestyle behavior that it's going to take up an awful lot of time, but it doesn't actually, in my experience. It's an investment now to stop problems later. And we also be mindful that if we don't speak out to our patients and service users about dangerous behaviors, in a way, you could be seen to be endorsing them. So don't count the consultations or the consultation time, but make the consultations count. And the last slide, please. Thank you again for listening to me. I apologize for the technology difficulties. There's go make it happen is what we'd ask you to do, and obviously more information at makingeverycontactcount.ie. Thank you.
Thank you very much, David. Really, really great presentation, and loads for us to talk about when we get to the panel discussion at the end. Lots of things to follow up on, particularly the patient-centered approach that you described so well, and also the many services and supports that we can signpost our patients to, and the volume of those that have increased in recent years. So plenty for us to talk about as we go forward. So thank you very much for that really great presentation to kind of set the scene and outline the really good work that's happening in general practice, and also the evidence and the success that is really helpful for us as we try and scale up further across all of our community and acute services as well. So without further ado, I'm going to move on. Our next piece is a short video collage showing elements from lots of promotional videos that have been developed by our community health organisation colleagues, our health promotion improvement teams, and others, just to give a snapshot and a kind of a demonstration of the variety of work that's happening. So I'll just hand over now for that short video, and then we'll have some more examples of really good practice happening in our health service. So I'll hand over to the video now. Thank you.
Making Every Contact Count supports using everyday conversations that staff have with patients to prevent and manage chronic disease. Good health and well-being is an important factor in helping people to live well for longer. However, we live in a world where it is easy to make poor lifestyle choices. Making Every Contact Count is about finding appropriate opportunities to have everyday conversations about modifiable lifestyle risk factors. If you work with the public, you are in a position to support people to make good choices. 60% of hospital bed days.
Participants complete 8 modules on HSE Land e-learning on topics such as tobacco use, harmful alcohol and drug use, physical inactivity, unhealthy eating, obesity and mental health.
You know, as a nurse, I felt like I had a background knowledge of these chronic disease prevention strategies, but actually by doing the e-learning program, it has really strengthened my knowledge in these different areas.
I found the online learning modules were great for creating new examples and different scenarios that you wouldn't think of yourself. I think when we think about making every contact count, you might come across the more obvious ones such as like smoking or alcohol, but the online course brings in a whole other different types of scenarios that prep you for the wide variety that you see in patients.
After participants have completed the 8 modules on HSE Land, they can register to attend a half-day workshop entitled Enhancing Your Skills, where they will get to practice what they've learned.
It also gave us the opportunity to work around difficult conversations and navigating those conversations for clients who may be kind of stuck in a rut. I feel now when I'm with my patients on the wards that I can pick up on, you know, something small they might have said, that I can now approach these conversations with the patients in a non-judgmental way, in a very natural way.
I found the workshop was a great tool to be able to practice the techniques that we were going to use with our patients. Topics like this can often be hard, particularly as I always used to think that I might jeopardize the therapist-patient relationship. But actually, after completing the course, I found that I had new tools and techniques and different ways to address it in a friendly, approachable and safe way, so that I was able to maintain that relationship but also make those changes for the patient.
All this training is available free on HSE land, and there are CPD points for both the e-learning and the workshop.
So pregnancy, it's a unique time in a woman's life where her incentive for change is at its highest. And despite this, she may find it difficult to change on her own, and she may feel criticised when the healthcare professional brings up difficult subjects. So I completed the Making Every Contact Count to provide me with skills that I could provide information and support to women in a non-judgmental and open manner, that if they weren't prepared to change at this contact, that they may be prepared to take up the support at the next encounter with a healthcare professional. I'd highly recommend Making Every Contact Count training to my colleagues. It provided me with skills, increased my confidence in approaching difficult subjects, and it also provided me with a lot of resources that I could use in my practice, and I think every healthcare professional would benefit from doing the course.
Yeah, the whole process of implementing MECC in the service has been a really positive one. Staff have been receiving the support that they need from the health promotion team in order to conduct the brief interventions. Now we have a way of evidencing all the good work that's currently being done in the services. We're in the position where we can repeat them if necessary and build on the existing relationships that we have with our service users.
So my role was to support the implementation of MECC on site here in disability services. And I suppose that is formulating an action plan, a communication plan, and engaging with staff on site to work through the process of MECC. And the reality is that they're already doing brief interventions on site, but we provide them framework to be able to see them get the recognition, to record it, and then to go on to evaluate it as they go forward. And MECC gives them that opportunity to get the recognition that they so deserve.
Another concern that some people might have before coming to the workshop is actually raising these conversations with patients. But what we actually know is that 92% of patients do want to make a behaviour change, and they need support and guidance in order to do that.
I had thought about making changes, particularly with my eating habits and trying to lose weight, because they were causing me problems. And I was very fortunate when I was in for an appointment, in nice friendly chat, brought up had I thought about my diet and making changes, and was extremely helpful.
Okay, thank you to everybody who contributed to all of the videos that made up that collage that we put together to give some flavour of the work that's happening across our hospital and acute services and our community services, across a whole range of different type of services and different type of professions who are already engaging in making every contact count. So delighted to see that. And we're moving on now to get some really in-person short examples of how this approach is really working in different settings. So first, we have 3 short inputs, and the first input, I'd like to welcome Mairead O'Driscoll, who's a public health nurse in Cork Kerry Community Healthcare, and delighted to have you joining us, Mairead, to talk about your experience in Cork, and I'll hand over to you now. Thank you, Mairead.
Thank you, Sandra. Good morning, everybody. My name is Mairead O'Driscoll, and I'm a public health nurse in Cork Kerry Community Healthcare in CHO4, working in the East Cork area. And I'm delighted to be here today. I'm very passionate about about MECC and the rollout and implementation of it around the country. So just to give you a brief overview on our experience in the East Cork area of rolling out MECC to our public health nursing colleagues and community registered general nursing colleagues. So I will share my slides. Now just checking this looking okay.
Everything is beautiful, Mairead. Thank you.
Fantastic. So I suppose the first thing I will talk about is, having introduced myself there, Cork Community Healthcare. I suppose the first thing really for us was the impetus, what created the impetus for us to really want to develop the rollout of MECC in our area. And I suppose we know first and foremost that we have responsibility as healthcare professionals to practice within that framework of chronic disease management, considering that, and we've heard statistics from our earlier speakers, that 1 million people in Ireland today suffer from a chronic disease. That's 1/5 of our population. And that's diabetes, asthma, COPD, and and even some mental health disorders. And of course, around 65% of our over 65 cohort suffer from one or more chronic diseases. So that was really the background, and particularly, and I'll just move forward here, looking at that public health nurses have 5 million patient contacts per year. And another part of the impetus for us was in CHO4 was really a renewed look at our public health nursing role definition, because particularly in the last number of years, there's been a huge focus on the curative, on our clinical care, but reminding ourselves that we do have that remit whereby our role incorporates formal health education, prevention, health promotion activities. But I suppose sometimes with increasing clinical workload, the health promotion and education aspect becomes contracted or squeezed out. So we are uniquely placed as well, that realization that we're uniquely placed as home visitors. There is a specific insight into the world of the patient and the service user when we're in the patient's own home. And it's a really private space to deliver those brief interventions. So it's just acknowledging that for ourselves. And of course, naturally, there are challenges, and we've heard some of them mentioned today, around all of those competing demands and engaging staff in rolling out, making every contact count within any community care area. Of course, there are challenges with delivering enhanced community care. That shift towards community-based services is really welcome, and we know we need that. However, there is an increased workload that can be acknowledged, particularly around early hospital discharges. Many of the community care areas would recognise this, and many of these challenges will be recognisable not only to public health nursing, but also actually to many of the other allied healthcare professionals in the community. Reduced staffing levels, we know, have created a problem in terms of recruitment and retention, and of course the altered working environment in the post-COVID era. So overall, and it has been mentioned previously, that perception that delivery of MECC will create an additional workload within an already stretched workforce. So these were the challenges in CHO4 East Cork area that we had to look at as we really made a concerted effort to implement this. And our background, of course, that policy document there from 2022 for enhancing and the protocol for making MECC work. Our proposal in East Cork was that all members of our community nursing team would be supported in completing the MECC programme, the online modules and the practical workshop within the calendar year of 2023. So we started this in July 2023. And our objective, which is the objective overall of making every contact count, and we've heard it here today, is equipping our staff and colleagues with the skills and knowledge to promote and support that positive lifestyle change during our client interactions, to promote health gains overall and of course chronic disease prevention. So it was a call to arms for us this time last year. Achieving successful implementation, we really had to look at this because crucially, we needed the buy-in of members of our community nursing team. Now, this was across 3 health centres, Middleton, Youghal and Cloyne, and we had 24 members of staff at that time in our nursing team. So we really looked at pre-programme planning, Firstly, I myself gave an oral presentation at one of our area meetings and distributed supporting literature, directing staff to the HSE or HSE Land programme. And managerial support was a really, really big thing because, again, you know, covering 8 modules, a half-day workshop, there is a perception this is all going to take time out of that busy workload for public health nurses and community nurses. So in this instance, our managerial support system was really good. Our assistant director and director of public health nursing guaranteed that protective time for each staff member. So for someone like myself, who's a job sharer, perhaps doing those courses on our time off, they would have given us time owed or time in lieu to support that. So that was really important. And of course, evaluating it afterwards. So our outcome really was that 23 of our 24 staff completed the programme, both the online modules and the workshop. And one of the things we used also, I should have mentioned, was we took advantage of the positive note of group dynamic. So what we did was we liaised with our health promotion and improvement colleagues to arrange the workshop so that all members could attend on the same day. So that was a really supportive situation. 23 of 24 staff completed it. One member went on maternity leave just before the workshop. And our recommendations coming out of that, having evaluated, we did see a really high value to practice, as has been mentioned previously, coming out of this demonstrated. So therefore, we recommended that the MECC, the online and the workshop, would be included in the induction for all new staff, that staff on extended leave would be facilitated at the earliest possible time to complete the programme on return to work, and that any staff who hadn't completed it would be supported to do so at the earliest opportunity. And again, really good management support we were lucky to have in this instance. And just in terms of the benefit to service users, I've just given a very, very simple example of a benefit to a service user here, because again, that perception that something is going to take a lot of time. In the weeks following our completion of MECC, one of the staff in our health centres there took a phone call from somebody seeking advice and support around the emotional health of one of their adult children. Now, one of the things that we had done as part of our rollout of MECC was to laminate the service directory for our area and place it beside every public health nurse and community nurse's desk. So in this instance, that proved very beneficial in facilitating the support to this patient, because our service user, because we were able to direct that caller very quickly and easily to the correct mental health supports in her area. And she was really expressed a lot of gratitude, because until then she stated that she hadn't known where to turn for advice. So that was really a very short intervention that really had a high impact. That's myself and my manager there on completing our course. And some testimonials here from staff. When we did our post-course evaluation, we saw really, really positive feedback from staff around, gaining new skills and preventing those missed opportunities. Are really positive around all disciplines working together to provide positive outcomes, and incorporating brief interventions. It's possible regardless of how busy we are. And again, getting that necessary expertise and skill so we can confidently deliver those interventions. And finally, a thank you to all here today for attending, because it's in attending and listening to other colleagues and listening to the experts that we know we really can make an impact on the lives of those with chronic disease within our sphere of influence. So thank you.
Thank you, Mairead, and a lovely way to finish, and a really fantastic presentation of the work that's happening within your public health nursing team in Cork. So well done to everybody. And lots of things you mentioned there we pick up in the panel discussion, really important things like the managerial support, the protected time, and the practical things like the laminated signposting documents and things like that that really help staff to link patients and service users to the many community and voluntary supports that are there. So fantastic, Mairead. Thank you very much. And we have another now short presentation, again, to give a real flavour of the really excellent work that's happening around the country. And now I'd like to introduce Jacinta Renehan from the Midwest Disability. Jacinta is a Disability Training Services Manager in the Midwest. And Jacinta, I'll hand over to you now to outline the great work that you're doing in Clare. Thank you.
Thanks very much, Sandra. Good morning, everyone. So I'm going to be giving just a little brief introduction to our service here in Clare and talking about the very positive experience we've had with implementing MECC in the service. So if you just bear with me a second, I'll just share my slides with you there. That's good. Everyone can see that?
That's perfect, Jacinta. Thank you.
Thanks. So again, just by way of introducing our service and who we are. So we are the Midwest Disability Training Services. We provide individualised and centre-based supports to service users with disabilities. And I suppose we have a responsibility to promote, health and well-being and support people to make informed choices about their health and general well-being. So we have 45 staff across Limerick and Clare supporting 227 service users across 5 locations. Again, we have a very diverse service user profile. They're aged between 18 and 75. We've got people with intellectual, physical and sensory disabilities, with acquired brain injuries, ASD, ADHD and mental health. Some live independently, some live at home, and others are supported in full residential services. So quite a diverse service user age and ability profile there. So when we were approached by the MECC Midwest team about implementing MECC in our services, there was a couple of things that we had considered, and one was obviously the benefit to our service users and to service delivery. So I mean, on examination, it was very clear that MECC complements disability standards by addressing health and well-being as an integral part of service provision. And most importantly for us, then it provided staff with the training, support and competencies to effectively implement that programme. So it aligns very clearly with our own policy, new directions, interim standards, and it upholds service users' rights to make informed health choices. It also embraces a person-centred approach, and it ensures quality by integrating health promotion into service delivery. So look, we're all pretty clear what MECC is. I mean, it's a HSC behaviour change programme, and it's aimed at preventing and managing chronic disease. But again, most importantly, it provides health and social care professionals with all the skills necessary to do the brief interventions and to raise the lifestyle behaviour changes with patients and service users. So again, evidence shows that 30% of cancers and 80% of heart disease and diabetes could be prevented by addressing those modifiable risk factors such as smoking, alcohol use, poor diet and physical inactivity. And chronic disease has a significant impact on our population and health services. So for us then, the consideration is how, why MECC matters so much in disability services. And I suppose it's important to note that the people that we support are at much higher risk from chronic conditions like asthma, COPD, coronary heart disease, hypertension, stroke and diabetes, with nearly 65% of people with disabilities having a diagnosis of one or more of those conditions. And that compares to 45% among the general population. So it's very clear that disability services have a responsibility to support service users in their health and well-being. And MECC principles align very closely to our own core values and to those of the interim standards for new directions. So then it was about looking at why disability services matter so much in MECC and about the opportunities that we have within disability services. So MECC is built on a broad evidence base around behaviour change, but disability services are in a really good position to promote awareness of the benefits of those changes. We are environments with endless opportunities to provide brief interventions around behaviour change, and our relationships and our knowledge and understanding of service users mean that we can provide more appropriate interventions and support ongoing behaviour change. So when it came to actually implementing the program in our service, we looked at the preparation around the whole thing, and that was very important. So we had to ensure that there was staff buy-in and establish that at a very early stage. I mean, that happened very quickly because it was clear that, you know, disability services, you know, is fertile ground for a program of this nature. So we engaged with the health promotion team, and a health promotion officer was assigned to our service, which helped us set up local implementation groups and supported the groups then to develop communication and action plans. So the staff training, then we embarked on this in, I think it was Q2 of last year. So all staff completed the online 8 modules, and then in July we arranged the in-person Enhancing Your Skills workshop, which was received very well by all staff. Service user awareness then was very important, and through our advocacy groups we spoke to them about implementing MECC and introduced them to the health promotion officers, and, you know, to get buy-in from service users as well around what to expect. So then it was around adapting MECC to suit our service and tailoring, we'll say, the MECC recording systems to make them quite simple and easy to use. So we adapted the recording material and we developed a service directory. So then when it came to actual implementation, we agreed a go live date, agreed a launch party, which was most important for service users. They were all getting on board with that. And that meant then the commencement of brief interventions. So, you know, once we began to implement MECC, we received ongoing support from the Midwest MECC team. And I mean, the health promotion officer was in and out, and a very welcome kind of addition to the team and known to all service users at that point. So I suppose, you know, looking at how MECC has impacted on service users and our capacity to deliver a quality service here, I mean, we've seen improved health and well-being outcomes achieved through individual brief interventions with service users, a MECC enhanced timetable where new classes and activities, you know, providing opportunities for group interventions have been included on the timetable. So there was also things like initiatives like anti-bullying events, healthy eating days, and activity workshops included on the timetable. So another piece for staff then around training was the Healthy Food Made Easy program, where through engagement with the health promotion team, some of the staff here were trained to deliver the program on site, which is now included on the timetable. It was important then that we continue to foster positive relationships and partnerships with service users and providers. And we've seen enhanced quality of life for participants. So again, working with the key workers, working with service users, it's about regular progress check-ins with service users and strengthening that trust piece and assisting with, you know, ongoing support around particular referrals and such. So for us, again, you know, what was the difference with what made MECC, you know, what made the implementation so seamless in the service? So key was the support from the implementation team. And I mean, from, you know, the MECC mobilizers to the health promotion officers, they really couldn't do enough for us and for the service users around, you know, supporting the implementation, being involved. They became very known and welcome members when they were out of the service. So staff training as well was very important, like the HSC land training that was mentioned there earlier, and the in-person workshops. It really built, you know, the confidence with staff around conducting the brief interventions. See, for us, like a lot of this work, the MECC program underpins a lot of the work that staff are already doing with service users, but having that additional layer of training meant a lot for staff then as well. Adapting the program for our service was important so that it was easy and seamless. You know, it wasn't an additional layer of recorded integrated fairly seamlessly, and we needed to ensure that it was kept live as well. So we have entered, we've included MECC as an agenda item in our daily team meetings as well as the quarterly service improvement meetings as well. So that, you know, it's constantly on the agenda, and it's like, okay, was there any brief interventions today? Is there anything we need to be aware of? And just maybe that if you had a service user who would benefit from, who had engaged with a brief intervention and might benefit from another staff person maybe following up with that as well, just keeping the whole piece, keeping it all alive. So another important piece for us was around celebrating service user successes, which led to peer role models. You know, there's nothing like seeing a peer doing well with something or getting praise for something to encourage somebody else to become involved in as well. So it was about utilising existing resources, and that was referral pathways to national local services, being aware of that, inviting in guest speakers, you know, and just keeping the whole MECC piece a very positive experience for staff and service users. And then it was just around the working collaboratively with the Health and Wellbeing Department. So what's next for us with MECC? I mean, continued monitoring of the program. So we're continually monitoring and recording our brief interventions, both the individual and the group interventions. But also we're doing a piece with MECC Midwest, a collaborative piece around increasing the accessibility of the signposting documents. So that's a kind of an ongoing thing we're working with at the moment. It's very important as well that we continue to include service users in the planning of MECC events and initiatives, because it keeps it live for them as well. So constantly going back to the advocacy group and looking for suggestions around maybe you know, healthy eating days, maybe activities, and even looking at, you know, the Health and Wellbeing Department staff initiatives like the Steps to Health Challenge. Like we run that parallel to a Steps to Health with service users as well. So there's nearly a competition piece going on. So it's good. It just keeps everyone involved and utilising what's already there. So it's important that we continue to get this feedback from staff, service users and stakeholders, and that MECC continues to be an enjoyable process. It's not something that's imposed upon people, but it's like just complementing what's already occurring. So the continued staff training and development, and just keeping up those connections with the community organisations and the voluntary groups, and getting the guest speakers in from the smoking cessation service, the drug and alcohol, integrated drug and alcohol service, all those kind of things, just keeping those connections going. And that's pretty much it. I mean, again, I couldn't praise the support we received from the MECC implementation team in the Midwest. I mean, it was just, that was the real piece for us. So that is it from me.
Thank you very much.
Here now.
Thank you very much, Jacinta. That was a really great picture of the work that you're doing in the Midwest in your disability service, and just the way you described it in terms of a fertile ground for MECC, and I suppose just your relationship and understanding the needs of your service users is just a really key component. And again, another piece that we'll try and pick up in the panel discussion. And it's also the first time I think I've heard of a launch party for MECC. So I think that's also a really, really good idea. So look, we'll talk more about that. So thank you very much, Jacinta. And now we're moving on to the next short presentation from, and I'd like to introduce Sinead Rosengrave, who's a CNM2 in the surgical day ward in Ennis Hospital. And it's great to get the hospital perspective now, Sinead, and delighted to have you with us today. So I'll hand over to you. Thank you, Sinead.
Absolutely. Thank you, Sandra. Good morning, everyone. And thank you all for inviting our department to be part of this webinar. It means a lot, and we're very grateful for the opportunity to showcase what we are offering to our patients in relation to MECC here in Ennis. So I might just share my slides there. Okay. There we go. So I'm aware that many of you here today in this webinar are from different disciplines. So I just want to give you a little bit of brief background of our department within the UL Hospital Group. So as you can see here, there are 6 hospitals within our group in the UL Hospital Group. So our hospital, we're a Model 2 hospital, tertiary outside of the main hospital in Limerick. So our hospital is the one up there on the left, just to give you an idea. We are a relatively small department. So there's just myself leading the team there, and there are 5 staff nurses within the unit. So there's our day ward in action. One of our urology doctors was quite willing to have his face for the day today with you all. So basically we have a 12-bed capacity within the unit. There's a variation of surgeries that take place here, from urology to gynecology, maxillofacial, general surgery. Just to give you an example, I suppose our patient profile are fit and healthy. We're a Model 2 hospital. So that means that all our general anaesthetic patients are pre-op assessed and deemed suitable for Ennis. Invariably, some of our patients would have comorbidities like asthma. They would be immunocompromised, which in turn may impact on their post-operative wound healing. So for us, making every contact count and brief interventions are invaluable in order to prevent post-operative complications. So where MECC and making every contact count begins for us. For us, Niamh Keating was employed by the UL Hospital Group as the Health Promotion and Improvement Officer about 18 months ago. And after meeting with Niamh, she was here on site with us in Ennis. And we agreed on meeting with her that, the surgical day ward was an ideal area of implementation for MECC, I suppose, in a structured and formal capacity. As Jacinta said there, we're doing this work anyway. In the background, we are doing some of this work, but it's nice to have the structured approach with making every contact count. So we focused on smoking primarily, as we felt, again, going back to Dr. McConaghy, we have a short time. I might think differently after his speak today, a short time to make that brief intervention. So I suppose we felt that maybe, if we understood the patients were coming in for surgery on a given day, we didn't want to deter from that. We wanted to make sure that they were comfortable and relaxed and not nervous or anxious in relation to their surgery. So we didn't want to be harping on about all the different aspects of MECC for that short window of opportunity that we had. So I suppose in the last 12 months, we have focused primarily on smoking, maybe just, as I said, to plant that seed or just to have that brief conversation just in relation to how stopping or quitting or reducing would have on their post-operative complications in relation to wound healing, anesthetic complications that can result as a result of smoking. So I'll just move on there now. And here, this is again the day ward with our signage and two of my nurses there in the unit, Anya and Sive. And again, in order for, I suppose, making every contact count to be a success, it's really important, as the other speakers have said, that all staff are on board. The training is provided, the protected time is there, they're given the opportunity to get more information and knowledge behind why making every contact count is so important. So all the staff within the unit completed the e-learning program within a specific time frame. I set a time frame that we would all have the training done, and once we were all trained, then we went live. So we began last May. And our face-to-face training, we're lucky we're getting through our staff face-to-face training. Invariably, it takes time it doesn't happen that often, and it takes time to get all the staff across the line on that. So we're still in progress with that. It was also really important that staff were well informed and equipped in order to roll it out. So it was really important, as again, the other speakers have already said, that we had the information, we have our leaflets, our posters, the electronic referrals to quit, the MECC recording book, in order to have the data available as to who we were referring on, and just to have it to fall back upon as a paper trail. So lucky for us now, it's custom and practice that all patients who do smoke are offered intervention, and in the brief intervention, does and has been proven worthwhile. In relation to staff engagement, for any CNM2s that are attending or on this webinar today, they know how difficult a job it is to get buy-in. Again, another term that has been used by my colleagues in the other speakers. Buy-in is really big, and staff engagement. So it was really important that a culture change had to happen within the unit. And Sive, my nurse there in the white top, has proven invaluable within this unit, and she's an absolute champion, and she's leading. She's certainly, I'm the CNM2, but she's leading out on the making every contact count here and the brief interventions in relation to smoke. And she's so passionate and enthusiastic about it. And you know what? It feeds on to the other nurses. It feeds on throughout the department. And there's such a positive vibe about it now, that we're just, as I said, it's implemented, and there's no issue now. It's just a custom and practice, as I've said. And I think Sive certainly deserves a lot of acknowledgement. I was hoping she'd take my place here today, but here I am. So as I said, we went live in May 2023 in the formal capacity, so over 12 months now. So what we have done to date, I suppose our client record is how we monitor the record of who has been referred in relation to making every contact count. So in the last year, we have referred 58 patients to Quit Midwest. And that is, you know, the numbers we're happy. However, I suppose an area for improvement when you're doing this and you're preparing for talks, it really just highlights, you know, things that maybe we need to work on. So if a patient had been approached about quitting and they declined, you know, there is a capture point there that maybe we weren't filling out the client record. So we're looking at that as a quality improvement going forward, that we will complete the record on everybody, regardless if they accept or decline the quit referral. And we have statistics there just from the first quarter of this year in relation to the Quit Midwest. So just in the first quarter of this year within our group here, you can just see the Model 4 hospital in Limerick has 30 referrals. Here in Ennis, Model 2 hospital, we have 28. So we're delighted with those results, and we really just want to increase them. That's our main objective. So just again, what's working for us, as I've said there, our MECC champion, and I'd like to think we're all MECC champions, but the SIVE is certainly leading out on that at the minute. The referral process, it's very easy for to refer, and again, it's custom and practice, as I've said. And again, the other speakers, the buy-in. The buy-in is the thing, you know, but it boils down to communication. It boils down to your staff having the ability to communicate effectively with the patients and to show them the benefits of quitting and how important it would be for them. And just to, again, what's working, I suppose, the patients receiving the positive feedback, they leave our unit post-surgery with their post-operative instructions, prescriptions, different things, but they're also leaving, if they smoke, with their quit information, which is, you know, it just goes to show that we're adding something to their visit. Areas for improvement, again, what I said there, you know, all the interactions may not necessarily be recorded in our book, so it's something we're looking at going forward. Again, just to sustain the momentum, sometimes things can dwindle, as we know, and initiatives can fall to the side. We really do not want that to happen. And going back to Dr. McConaghy's talk this morning, you know, I really, you know, time, we use that against us all the time. But I think maybe, you know, we'll look at it in other aspects of MECC going forward, that we'll try and see that maybe time isn't as much of an issue as we're making it out to be. And probably what I would like to see within the unit is in time just to see those referrals that we have sent to quit, to get statistics on did they actually quit, or where they are in their journey, have they reduced, just to get more statistics and figures, I suppose, to see that what we're doing and is it actually working. And this is, as of yesterday, our most recent face-to-face training that we had on here in Ennis, which was great. So it refreshes everything, and it just gets more people trained and tuned in relation to MECC and what it is, and to keep the flag flying, you know, for even those brief interventions, just to make sure that, you know, any little bit at all that we can offer our patients is really important. And thank you all for listening.
Thank you very much, Sinead. That was fantastic to get the hospital perspective, and particularly in a surgical ward, for the patients coming through your doors there, there's never a better opportunity. Health is their top priority at that time. So really great work happening in your service there, and lots for us to follow up on now. Next in our panel discussion, particularly the sustaining momentum piece, I think is really valuable. So thank you very much, Sinead, again for that hospital perspective. So now I'm going to move on to our final element of the webinar this morning, which is our panel discussion. And Dr. David McConaghy is still with us from the earlier presentation. And I'd now like to introduce the remaining members of our panel who are joining us for this part of the webinar. So first of all, I'd like to welcome Dolores Donegan. who is the Programme Manager with RCSI Hospital Group. And again, Dolores, delighted that you're with us this morning to provide further hospital perspective to add to what Sinead has covered there. So delighted to welcome you. And next up, we have Bedelia Collins, who is the Health Promotion and Improvement Manager in the Midwest. And again, we have the Midwest strongly represented this morning, so delighted to welcome you, Bedelia, also this morning. And then our final welcome to Duana McArdle, who is a Senior Health Promotion Officer and the lead and mobiliser for MECC in the Midlands Louth Meath CHO area. So delighted to welcome you, Duana, as well. Now, David was having some technical difficulties earlier, so hopefully you can hear me okay, David, and delighted that you're still with us. Fantastic. So we have a number of questions that have come in through the Q&A box during the webinar, and just to thank people for sending those through. Maybe to start with you, David, because you gave a great presentation and some case studies of particular patients and others that you've met. Could you just say a little bit about what the patient reaction or how they responded to being asked about health behaviour or lifestyle risk factors?
Yeah, I think the first thing when it comes to behaviour, we all want, regardless of what we all want to live better, healthier lives. And most, in my day-to-day job, most smokers want to smoke less. Most people who don't exercise would love to be more mobile. Most people who have their weight isn't optimal for them would like to have an optimal weight. And I think that that's one of the things. Everybody fundamentally wants to live a healthy life and wants to change. So I think early in my career, I would have been worried that if you bring these things up with people, that they'll take offense or that. But I think that the beauty of MECC is it teaches us how to broach it in a very non-confrontational manner. And nowadays, vast majority of people are more health literate to even to some degree, so they're expecting to be asked. And certainly I'm involved with trainee GPs, and we always tell them, if you don't bring up a conversation about smoking, exercise, diet, that you're probably you're part of the problem, and patients are expecting this now. I think that the beauty of MECC is that it brings it up very well. And things like saying, are you smoking at the moment? Yes. You should give that up. Do you feel at this moment in time you're not in the right place to do that? And say, the patient might say to me, I know I'm not really interested at the moment in smoking. My life's too stressful, I can't. And then what I would leave it open-ended with them and say, I can guarantee you sometime in the next 365 days, you will wake up and say, I don't want to smoke anymore. And when that day happens, you come back and talk to us and leave it sort of very open, so that even if you don't get a buy-in from the patient service user there and then, that's not to say that you won't get them again. And I think the important thing is, it's keeping that relationship open. And that's perhaps for us in general practice, we're seeing patients, for example, in the chronic disease program, we're going to see them twice a year anyhow. But it's slightly harder. For example, Sinead, our hospital colleague, has done great work on a surgical ward. It's brilliant to see in that kind of setting. Say, well, yeah, you mightn't want to stop smoking now, but there is help down the line whenever you decide. So it's building that relationship, not falling out with the patient is very important, because where possible. But it's sort of most people's their desire to change and live healthier lives is there, and our job is to identify and nudge them toward it.
Perfect. That's great. And that relationship being core is a really kind of fundamental piece of it, and very well described, David. Thank you. Dolores, just to follow on to really fly the flag for the work that's happening in the hospital side of things. One of the things that came up through a number of the presentations, and Sinead mentioned it, particularly in terms of the surgical day ward in Ennis, the importance of champions. And just in terms of champions within the acute service, there are lots of champions in lots of hospitals really flying the flag for this prevention work. Is there anything you'd like to add in terms of how we can kind of support and build those champions across our services?
Thank you. First of all, thank you for the opportunity to be here today, and thank the others for the presentations. I was really impressed with Sinead and Jacinta by providing that time for staff to actually participate on the programme. Really shows the impact that it will make if we look at the impact from our acute centres, I just looked at our hospital group, and back in 2015, 16.9% of beds were occupied by patients with chronic diseases. This would be cardiovascular, diabetes, respiratory, or cancer. And then when I looked, and they were taking up to 41.4% of all inpatient bed days, where that has reduced now. I looked at the figures in 2022, and that had reduced down to 13%. And then also the inpatient day beds is only 20%. So MECC is making inroads. It's really, really is supporting patients and signposting them and giving them the power to empower patients to take the, make the behavior changes that they want to do. We also have seen a huge reduction in the amount of chronic obstructive pulmonary disease patients attending, that they were up to 4.6% of the inpatient day beds, and that's down to 2.9. I know there are other programs, the chronic disease program and all that is working, but this MECC is really making the supports and the impact that are there. It is difficult for staff to attend training because it's not mandatory. But when you see the good work that's happening, Sinead, Jacinta there, that, when we're making the opportunities and giving protected time for staff to do it, and then seeing the impact that it's making. And even in our hospitals, we can see the increase in patients being transferred to, being referred to the quit or to our alcohol liaison services. This, we can really see the impact that this will make on the access for patients into services.
Yeah. That's excellent. Thank you, Dolores. And Bedelia, I'll come to you next. And just one of the things that came up through all of the presentations was just that partnership piece. And I know obviously in health promotion improvement in the Midwest, there's huge partnership working across all of the different community and voluntary agencies. And that's such an important piece in terms of signposting our patients and service users out to the huge number of other services that are out there. So Bedelia, could you talk a little bit about how you in health promotion improvement in the Midwest and across the country in the health promotion improvement teams, how you support MECC through that partnership working?
Yeah, look, it's really important. The brief intervention which comes with MECC is crucial, that conversation, but what you have to have is those to acknowledge and to highlight all the services that are out there in the community. So as an example, a lot of our CHOs, the MECC mobilizers would have tracked all the community services that are there and would put them in a kind of an accessible layout or format for the frontline health professional when they're doing a MECC intervention. So that helps. What also, I suppose, in some of the CHOs, we've taken it a little bit further. We have developed the relationships with particular organizations. So I suppose just as an example here in the Midwest, we work with our local sports partnership. So, and we just have made a digital signposting piece so people can just signpost in referrals. Our physiotherapists within the community signpost as service users who've had a MECC intervention into the local sports partnership, and they then pick up, work with that person to identify a suitable local physical activity program. So to date, the early figures are telling us that 26% of those referrals are actually now physically active in their local community. So that's just an example of the partnership, but partnership is all about the relationships. It didn't just happen overnight, as you all know. It takes time. You've got to, I suppose, even working with the acute settings and the community settings between ourselves, we have to acknowledge those pressure points. We've got to go with low-hanging fruit. But I think one of the things that came across very strongly today was that point about celebrating the wins. It was that point about being consistent. It was keep coming back, tracking your success stories. And I think that's all really important in terms of partnerships as well, whether you're doing a partnership between acute and community or doing a partnership between community and onwards with community partners. Tracking success stories is important, keeping it live and celebrating the stories like we're doing here today and all the good work that's happening. And this keeps the energy going and I suppose reminds people the value of MECC. In the end of the day, we're trying to, I suppose, slow down that revolving door into our A&E services. And the only way we can do that is keep people living well at home. So this is what it's all about. And it's starting to happen, as Dolores has just highlighted there in her figures.
Fantastic, Bedelia. Joanna, I'd like to bring you in because I think you're the face-to-face person who's making all this happen and supporting services in your area, and your colleagues are doing likewise in the other parts of the country. So could you just tell us a little bit about what your role involves in terms of supporting the scale up of MECC in your area, and just give us a bit of insight into it, please?
Thanks, Sandra, and it's great to be here today. I suppose my overarching role is, as I see it, is to make everybody's business in a planned and coordinated way, and my colleagues around the country. I suppose our first task would have been to mobilise the HPNI department and mobilise that system to begin to coordinate how we would support sites and teams and everyone in the service to see how MECC was relevant to them, and to paint the picture of making every contact count being the bridge between HSE clinical services and the community and voluntary services and funded services and Sláintecare Healthy Communities. Programs such as Healthy Food Made Easy, Triple P, social prescribing. So by painting that picture to teams and sites, and again, many people have talked today about busy clinical teams need to see that it's relevant, that it isn't extra work, and that it's putting a framework around what they're already doing. So through the mobilisation of the teams, all of the national supports around implementation, that can be done to then see how we can walk a service user through a clinical service in the HSE, then through MECC interventions into a social prescribing service, for example, where they can then access stop smoking clinics, they can access social supports in a way that their journey is made a lot easier. So I see the role of the MECC mobiliser as a facilitator of a service user journey through the health system.
So it's really joining the dots, isn't it?
Yeah.
It really describes how you're the glue that's kind of holding a lot of these pieces together, or kind of joining these pieces up, which sounds really great. One of the questions that came up, Joanna, and you might be able to answer it, is just in terms of accessing the training on HSE land, and who is it open to? Could you say a little bit about that in terms of how people can access the training?
So the training is open to everyone, and especially the HSE land training. So that's available to everyone. It's just a matter of which option they select when they go on to HSE land. So it's open to the community and voluntary sectors, to our funded agencies, to core HSE staff, agency staff, and so on. So in our area, we would have a separate kind of email that we would send out if we get a query on that. So that can be shared, perhaps with national. That's really useful. So it's available to everyone, and then people can register for the Enhancing Your Skills workshops. And we would have many funded agencies, staff on some of those Enhancing Your Skills workshops as well, who are providing vital supports.
Brilliant. And we know from our experience that many of those that go to those Enhancing Your Skills workshops go on to become champions for the approach and the programme, and the people that they've engaged with on that workshop. And it's a really capacity builder in terms of implementing it in your service. The workshop is a real stepping stone to that.
Yeah, I really see even the role of the MECC mobiliser. I think everyone working in the health service is a mini MECC mobiliser, and should and could be, to champion the programme of making every contact count.
Fantastic. Thanks, Joanna. We're close to the end, but I just might ask one final question to you, David, if you don't mind, because it came in through the chat, just because you had mentioned specifically the chronic disease prevention priority with patients or service users with mental health challenges. And could you just say a little bit in terms of how MECC can support that particular patient or service user who's coming from that perspective?
Yeah, as I mentioned a little earlier, so people with kind of moderate to significant mental health issues often have terrible physical health. We know their smoking rates are higher than their exercise as well, like this. And this has been well, community mental health teams, certainly in my region, they're very in tune with this, and they will work on smoking cessation when the time's right with patients, and they're encouraged along. The good news is that any of those patients that we may encounter that have got medical card or doctor business cards, if they're over 45 years old, they will get enrolled in the chronic disease program, and at least every 5 years then they'll get a blood pressure check, their lipids check, a conversation about smoking, exercise, vaping, and body mass index done as well. So it's just important that we don't forget about often the focus with our mental health patients is on getting their depression, their psychosis looked after, but we mustn't lose sight of the fact that their physical health needs to be looked after too. And again, so much can be done with medication, but ultimately, as we've seen, it's getting people to weigh less, move more, stop smoking, sensible alcohol. All these things will add healthy years to our lives, to all our lives, but especially to this vulnerable cohort.
Fantastic.
Can I just say too that Mairead's idea where they drew up a list of local services and laminated this fantastic idea, and certainly in my practice we have a similar thing. We've all these essential services saved on a computer file that everyone can access, so that and not to forget just about HSE provided services, but the men's shed, the women's shed, a local walking club, park run, Xwell in our area helps with exercise. All these there's groups. Every locality has a sort of thing. We often see it through sports clubs as well. It'll vary from region to region. Urban will be different from suburban, will be different from country area. Yeah. But there are lots of, and actually the research would show too that if you can get people to motivate themselves, you'll exercise more if you go walking with your friend than you will if you go to an exercise class. So don't forget self-help as well. It's important to note. So thank you.
Perfect. Thank you, David, and loads there. And I think we could have had this panel discussion for much longer. So I'm sorry, guys, that we didn't get an opportunity to explore it in more detail. We're close to the end. So I think hopefully, as David said, there are lots of really practical things that have come out of the webinar this morning. I think we have to, I have to go to the closing element of it now. So on that note, I'd first of all like to thank the panel, and apologies for this discussion being as short as it was, but your input is really, really valued. And also thanks to the presenters, all of the presenters who gave such a valuable insight into the work that they're doing, and all of those who contributed to the videos as well. So it's really great to get a sense of the work that's happening so that we can then look to how we can build on that and scale that up. The event today didn't happen by accident. There's lots of hard work behind the scenes, and the organisation of today was supported by a planning group with Dolores, who people would have seen on the panel, colleagues of Duana's, the MECC mobiliser or MECC lead in CHO2, Pat Conway, and in CHO7, Rosemary Plant. So really great thanks to you. And in our own health and wellbeing team, thanks to Eamon Keogh, who is on our communications team and has provided such expertise and support to us, and to Donna Doyle, who's the project manager for our MECC programme, and again who anchored all of the organisation for today, which I really appreciate. And just to say thanks to you all for all the on-scene work behind the scenes in pulling this event together. Finally, I'd like to thank my own manager, Helen Deely, who's the Assistant National Director for Health and Wellbeing, and is such an ally for the work that we do in health and wellbeing as a whole, and also, I suppose, specifically in our Making Every Contact Count programme. And thank you all for joining in. Thank you all for the questions that you put in through the chat. We may not have got to answer them all. Hopefully some of them I've got answered through the presentations or through the panel discussion. But we will also, I suppose, be putting up a slide at the end here to indicate where you can come to us directly if you have any questions or any follow-up queries, and where you can find information about our training and our programme and resources, and also how we can link to people like Duana on our panel and Rosemary and Pat, who helped organise the day, because there are supports within health promotion and improvement across the country who can help and support you as service leaders and service managers and healthcare professionals who want to implement MECC. So on that note, I hope the programme has been useful and inspiring to support you in making every contact count. And on that note, thank you again for joining, and hope to see you soon. Thank you.